Assalamualaikum warahmatullahi wabarakatuh to Miss Naziha and my fellow friends. I am Nur Imanina Batrisha bint Azhar, your ATM physiotherapy student, semester 7. So today I will be presenting about bronchiectasis. So first, let's take a look at the respiratory system. Respiratory system divided into two, which are conducting zone and respiratory zone. Conducting zone forms a continuous passage that carries air in and out of the lung. It contains of nose, pharynx, larynx, bronchus, and terminal bronchioles, while respiratory zone is the site of gas exchange. It includes respiratory bronchioles, alveolar ducts, and also alveoli, which is an air sac that is responsible for gas exchange. Anatomy of the lung, as we can see here, there are two sides of the lung, which are right and left lung, which descend from the trachea, or we call as windpipe, next to the branch called bronchus, and to the smaller branches called bronchioles, and at the end of the bronchial branch there are alveoli sac that are responsible for the gas exchange, and at the outside of the lungs there are pleura that are responsible to it for the optimal function of the lung during breathing. And at the bottom part there is diaphragm, which is a muscle that is responsible for breathing. For the lung lobes and segments, for the right lung, there are three lobes which are superior lobe, middle lobe, and inferior lobe. And for the superior lobe, there are three segments which are apical segment, posterior segment, and anterior segment. While in middle lobe, there are only two segments which are medial basal segment and lateral segment. And inferior lobe, there are three segments which are superior, posterior basal, and anterior segment. While for left lung, there are only two lobes which are superior lobe and inferior lobe. For the superior lobe of left lung, there are four segments, which are apical posterior segment, anterior segment, superior lingular segment, and inferior lingular segment. While for inferior lobe of left lung, there are three segments, which are superior basal segment, lateral basal segment, and anterior medial segment. Let's move on to the bronchiectasis. Bronchiectasis is defined as a permanent and abnormal dilatation of bronchi in the airways with impairment of mucociliary clearance mechanism that leads to inflammation and increase of mucus production. This results in frequent infections and blockage of the airways. There are three main types of bronchiectasis, which are cylindrical bronchiectasis, saccular ovarical bronchiectasis, and cystic bronchiectasis. The first one, which is cylindrical bronchiectasis, is the mildest form of bronchiectasis. It reflects the loss of the normal tapering of the airways, and the symptoms may be quite mild, like a chronic cough. The second one, which is saccular ovarical bronchiectasis, is a more severe form of bronchiectasis. It causes further distortion of the airway wall, and symptomatically affected persons will produce more sputum. The last one, which is cystic bronchiectasis, is the most severe form of bronchiectasis and the least common type. This often occurred in the pre-antibiotic era, when an infection would run its course and the patient would survive with residual lung damage. It will produce chronic productive cough and bring up a cup or more of discolored mucus every day. As we can see, these are the three types of bronchiectasis that can be seen from the high-resolution CT scan of the lungs. The first one is cylindrical, the second one is saccular ovarical bronchiectasis, and the last one is cystic bronchiectasis. For the prevalence, bronchiectasis can affect individuals of any age, but the overall prevalence of bronchiectasis increases with age. Mean age of patients with bronchiectasis is 65 years old and above, while in children, bronchiectasis is commonly misdiagnosed as asthma. In large parts of the world, bronchiectasis is more prevalent in men than in women, and in some populations, poor socioeconomic status and housing area can also contribute to the respiratory infection and the development of bronchiectasis. Next, for the etiology, people with genetic conditions such as cystic fibrosis and primary ciliary dyskinesia is most likely to develop bronchiectasis. The next one is drugs and alcohol abuse, recurrent lung infections and aspirate foreign bodies, history of tuberculosis or chronic lung disease, exposed to toxic gases or any substances that damage the lung tissue. And lastly, the children that develop lung infections with lung tissue destruction are at risk of having bronchiectasis later in their life. Next, for the pathophysiology of bronchiectasis, it started from the airway inflammation, which arises from the infection with microorganisms, predominantly bacteria. And it caused the formation of excess thick mucus. The thick mucus then crushes the cilia and causes further damage, creating an excellent environment for infection. Next, the immune response releases toxic inflammatory chemicals such as neutrophils that leads to fibrosis and bronchospasm if it persisted. And it finally causes bronchial dilatation or airway destruction and lead to bronchiectasis. Now let's take a look at the signs and symptoms of bronchiectasis. Symptoms of bronchiectasis can take months or even years to develop. Some common symptoms include persistent cough, abnormal sounds or raising in the chest when breathing, shortness of breath, chest pain, coughing up large amounts of thick mucus every day, weight loss or loss of appetite, fatigue and lethargic, thickening of the skin under the nails and toes, which is known as finger clubbing, and frequent respiratory infections. For the investigation, a doctor will conduct HRCT scan, which involves taking several X-rays of the chest at slightly different angles, and this produces a very detailed picture of the inside of the body and the airways inside the lungs. And the bronchi should show up very clearly. If the scan shows that a section of airways is getting wider, it usually confirms of bronchiectasis. And other tests may include blood tests to check for infectious agents such as bacteria, viruses, or fungi, sputum test, lung function test, which use a small handheld device, which is spirometer, to determine how well the patient is breathing and how well the lungs are working. And the last one is bronchoscopy, which uses a flexible tube with a camera at one end to look into the lungs to see if there's any foreign object entered the lungs. This procedure can also be used to obtain lung secretions. These are the example of the investigation done for the bronchiectasis patient. The first one is sputum test. The second one is lung function test using spirometer. And the third one is bronchoscopy. The common doctor management for bronchiectasis is antibiotics, which is a drug that used to treat bacterial infections. This includes oral form and inhaled form, or a nebulizer machine. The next one is macrolides, which is a drug used to treat infections and inflammations at the same time. Next, bronchodilators, which is used to help relax the muscle in the lungs and widening the airway. And next, the corticosteroids and mucoactive agents. Last one is surgery, may be considered in patients with localized disease that have not responded to treatment. When bronchial artery embolization is indicated with massive hemoptysis, and in severe cases, lung transplantation may also be considered. And next, the physiotherapy management for bronchiectasis patient. The first one is breathing exercise. Breathing exercise include breathing control, sleep breathing, deep breathing exercise, thoracic expansion exercise, and ACBT. It is performed to improve the pulmonary function. The next one is posterior drainage, which could help to assist in draining secretion. Next, manual techniques such as chest percussion and vibration. It could help to loosen the secretion and to assist in secretion removal. The next one is respiratory adjuncts such as flutter, acapella, and spirometry, which function to improve the lung function. Next, positive expiratory pressure, which is a technique that describes breathing against resistance. It can be performed through device or against pursed lips. Next one is physical exercise, which aims to improve aerobic capacity, fitness, and endurance. And the last one is patient education. Let's take a look at the subjective assessment for this patient. The patient is a 17 years old Malay female. She is admitted in Hospital Seberang Jaya on 13th of November 2017, and my first visit was on 14th of November 2017. Patient was diagnosed with bronchiectasis and the doctor management medications, which is antibiotics, and refer for chest physio. Patient complained of unable to expectorate sputum when coughing and having chest pain. For current history, patient complained of productive coughing for 2 weeks and was brought to HSJ by her daughter on 13th of November 2017. Chest X-ray was done on the same day and patient was diagnosed with bronchiectasis. Patient then warded on that evening and referred to physio on 14th of November 2017 for chest physio. No past history, and for past medical history, patient had hypertension since 3 months ago and on medication. For social history, patient lives in a single-story house with her daughter. They live near a factory area, no carpet and pets at home, and her hobbies are cooking and watching television at home. Pre-morbidity, patient can perform ADL such as bathing, grooming, eating, cooking independently. And for vital sign, her temperature is normal, which is 37 degrees Celsius. Her pulse rate is 85 BPM. Blood pressure 120/75. Respiratory rate is also normal, which is 20 per minute. And SpO2 is 96% under room air. Next, for the special questions, patient is healthy, and for medications, patient take quite a lot of medications, which are moderated, amiloride, amlodipine, cefuroxime, and brohexime. Patient is unemployed. Patient also not smoking and not taking any alcohol. She also has no bowel or bladder problem. For the investigation, chest X-ray was done on 13th of November 2017, and the result is bronchiectatic and reticular changes with bilateral mild pleural effusion. He has no unexplained weight loss. And finally, the patient's expectation is to be able to expectorate sputum. Let's take a look at the objective assessment. For the general observation, patient is a mesomorph elderly lady, conscious. She is sitting in a propped up position with a pillow supported at the back. She is looking weak, but she is alert and can speak in full sentence. For the local observation, no chest drain is seen. IV tube is attached on the left hand. CBD also attached on patient. No finger clubbing. No central or peripheral cyanosis, and no chest deformity. For the posture, patient has a slightly slouching posture. For the palpation, no tenderness at both upper limb and lower limb. Next, for chest examination, the first one is auscultation. They are cause crackle and reduced air entry at lower lobe of both lungs, which is due to secretion retention. Next, for the chest expansion using measurement, from the chest measurement above, we can see that the patient has reduced chest expansion at lower region due to reduced thoracic mobility. For the breathing level, patient has apical breathing, and for the breathing pattern, patient has a slow breathing pattern. For the cough reflex, patient has a productive, ineffective, and intermittent cough. And for the sputum, patient can expectorate minimal sputum, and the sputum is thick and white in color. Minimal sputum expectorated may be due to ineffective coughing technique. Next, for the percussion note, dull percussion note was noted on the both inferior region due to excessive effusion in inferior lobe of both right and left lung. And for the 3 balls incentive spirometry, patient recorded an average record of 700 ml reading, which indicates poor lung volume. And for the general range of motion, patient can perform active full range of motion for both upper limb and lower limb. Next, for the muscle strength and endurance, for the arm curl, patient record 10 times of arm curl in 30 seconds. But for TUG and 6-minute walking test, we cannot perform the test due to patient complaint of feeling lethargic. So for the interpretation, patient reduced of upper limb strength due to reduced mobility. For the back mobility, patient can perform all of back mobility independently, but she cannot hold in position for more than 1 minute when sitting at the edge of the bed due to complaint of dizziness. Next, for the analysis, for the impairment, patient has secretion retention over both lower lobes due to ineffective coughing technique. Patient has a reduced chest expansion over lower lobes due to reduced thoracic mobility. She has incorrect breathing technique due to poor posture, and she has a reduced strength of upper limb due to underlying condition. For the functional limitation, patient will be unable to expectorate sputum effectively. Patient will be difficult to breathe normally and difficult to perform activity without getting easily fatigued. And for the participation restriction, she will having difficulty in doing her hobbies, such as cooking, and she will be having difficulty in socializing with her friends and neighbors. For short-term goals is to reduce secretion retention over both lower lobes within 1 day, to improve chest expansion over both lower lobes within 2 days, to correct breathing technique within 2 days, and to improve upper limb muscle strength within 4 days. And for the long-term goals, to prevent prolonged hospitalization and to prevent secondary complications such as hospital-acquired pneumonia. Next, for the plan of treatment, the first one is breathing exercise. The next one is postural drainage. Next, manual techniques such as chest percussion and vibration. The next one is spirometry, mobilizing exercise, strengthening exercise, aerobic exercise, and the last one is patient education. Next, for the intervention. The first intervention is breathing exercise, which is ACBT. ACBT will include breathing control, thoracic expansion exercise, and forced expiratory technique. Patient in half-lying position. Patient will perform breathing control 3 times and 3-second hold on the last breath for 3 times per day, 3 times circulation for 3 sets. And also repeat the same repetition for thoracic expansion exercise and also forced expiratory technique. For the evaluation, patient able to understand the instruction fully and perform complete cycle of ACBT, but take quite a lot of time. Patient able to expectorate small amount of sputum after 3 sets of ACBT. And for the clinical reasoning, the ACBT is an effective method for airway clearance and improving functional capacity in patients with bronchiectasis by Syed et al. 2016. The next one is breathing exercise, which is the rheumatic breathing. Patient in half-lying, put one hand on the chest and another hand on the stomach. Breathe in slowly through nose and feel for the rise on the stomach while the hand on the chest should stay still. Tighten the abdominal muscle and slowly exhale through pursed lip breathing. Patient will repeat this exercise 3 times per day for 3 sets. For the evaluation, patient able to perform the diaphragmatic breathing slowly. Patient able to gain normal breathing technique after 3 sets of diaphragmatic breathing, and patient's chest expansion of lower region slightly improved from 1.2 cm to 1.5 cm after 3 sets of diaphragmatic breathing. And for the clinical reasoning, diaphragmatic breathing appears to be effective for improving the exercise capacity and respiratory function in patients with bronchiectasis. The next intervention is postural drainage. Position patient in side-lying position and place patient head lower than the lower limb level and patient facing the right side first, and stay in that position for 3 minutes one time, and repeat the same position but patient facing the left side, and stay in that position for another 3 minutes. For the evaluation, patient complained of dizziness during the last 10 seconds before completing the treatment. And for the clinical reasoning, postural drainage position help enables gravity to drain excess secretions from bronchopulmonary segments. Next is manual technique, which are chest percussion and vibration. Patient in postural drainage position, and perform chest percussion and vibration over basal region and repeat on the other side. 3 minutes on each side. For the evaluation, patient complied to treatment but she complained of dizziness at the end of the session, and patient able to cough out small amount of sputum after chest percussion and vibration. For the clinical reasoning, manual techniques such as chest percussion or vibration helps applying force to the chest wall that could create changes in the intrapleural pressure which are transmitted through the thoracic cage and assist in dislodging secretions. Next, in incentive spirometry, patient in sitting position, ask patient to hold spirometry at the chest level and inhale with maximum effort until the ball elevated 10 times for every hour and every day. For the evaluation, patient able to perform spirometry exercise with the correct technique completely without any complaint of dizziness afterwards. For the clinical reasoning, incentive spirometry is proven to be essential to patient care. It could improve pulmonary function and improve inspiratory capacity. It also effective as early emboliation, deep breathing exercise, and directed coughing. Next, mobilizing exercise. Patient in sitting position. Ask patient to perform active range of motion exercise for both upper limb and lower limb, 10 times for each limb, 3 times per day and 3 sets. For the evaluation, patient able to complete all the exercises slowly. Patient complain of fatigue and tiredness after completing the exercises. For the clinical reasoning, early mobilization interventions show decreased length of hospital stay and improved functional status in all the patients. And the last intervention is patient education. Educate patient about the condition and emphasize the importance of doing exercise frequently. Educate patient about the causes of the condition and how to avoid it. And advise patient to sit with a correct posture to promote better breathing pattern, and also educate patient on the negative effect of the poor sitting posture. For the evaluation, patient understand about the information given and patient understand about the importance of the exercise. Clinical reasoning, patient education is a process intended to facilitate learning and improve health outcomes for patients. For review, for assessment, for the next visit, I will auscultate patient. We assess patient chest expansion, observe patient's breathing level, observe sputum, amount of sputum, we assess patient's arm curl, and to assess patient's TUG and 6 minutes walking test if possible. And for the treatment, we will continue SCBT and breathing exercise, continue chest percussion and incentive spirometry. I will add thoracic mobility exercise for the patient and add strengthening exercise for both upper limb and lower limb. For the evidence base, the title that I've chosen is the effectiveness of active cycle breathing technique or SCBT and flutter device for pulmonary function in bronchiectasis patient. The first study by Altier et al. 2012 that include 36 stable patients with non-cystic bronchiectasis shows significant improvement for pulmonary function test on both groups, but SCBT group show better improvement in dyspnea score and SF36 physical health component score. And for the conclusion, SCBT and flutter techniques are suitable usage at home-based treatment, but SCBT show better effectiveness for managing bronchiectasis patient. For the next study by Attawil et al. 2020, which include 40 patients with bronchiectasis aged 55 to 75 years old, shows result of the oxygen saturation level and dyspnea that are statistically significantly improved in both groups post-treatment. SCBT and flutter group showed better improvement in pulmonary function test following treatment compared to the SCBT group alone. And for the conclusion, SCBT combined with flutter group showed better improvement in pulmonary function test. Regardless, both treatments are proven to be effective in treating bronchiectasis patients. These are the references for my case presentation. And That's all from me. Thank you.